This is Dementia Air Network, brought to you by Beyond Dementia Coalition, and I'm your host, Bruce Layton. This interview is part of our 2025 Symposium interview series, recorded during the second annual Northeast Georgia Dementia Symposium, hosted by Beyond Dementia Coalition and Alzheimer's Association. With me is Laura Wolf and Libby Dunahoo. Did I get that right?
You did.
And if you could share with us what you do and where you do it, that'd be fantastic.
I'm Libby Dunahoo. I'm the Manager of Advanced Care Planning for Northeast Georgia Health System.
I'm Laura Wolf, and I am Trauma Performance Improvement Coordinator for the Trauma Program at Northeast Georgia Medical Center, and I've been a nurse for over 40 years in critical care, trauma, and emergency medicine. We follow injured patients from onset of injury through discharge, looking for opportunities for improvement in care.
Okay. And can we talk about what I find very often is the gaps that exist between where care's been delivered in a formal setting and what happens afterwards, and especially with somebody that has dementia?
One of the things we do to promote discharge planning is on admission, we start your discharge planning. So you have a case manager, coordinator, social worker following you throughout your hospitalization to help coordinate your discharge plan. So they get to know you, your family, your resources, and you get discharged to your best possible self again.
Okay, got it. And after discharge, is there any continuity in terms of other providers? Do you get feedback from other providers after the fact, or is that not part of an overall care plan or in your domain, let's put it?
We actually, I wish we did. We don't get much follow-up. We do have case managers that follow up and call patients after discharge to make sure they're doing okay. But as for long-term follow-up, that is a goal of ours someday to have.
Yeah, got the follow-up. And I know we've spoken with Ashley Trammell, Cognitive Nurse Navigator over at the Northeast Physicians Group, right? Yeah, it's amazing the work that you're all doing in trying to make sure that there's that connection with patient, now somebody who's left into the wild, so to speak. And
one of the things one of our doctors, Dr. McCracken, always talks about is the thing that prevents someone having to come right back into the hospital is how well did they understand the discharge plan itself. So sometimes that advocate has to be sure they understand the discharge plan, what's needed for the patient to continue to get better at home instead of getting home and things kind of get worse. So that discharge planning from the beginning that Laura was talking about is including the family and caregivers so that they can all understand what the discharge plan is. It's not just to get you out of the hospital, it's to keep you out of the hospital so that you're not turning around and having to come back because things got worse at home instead of better.
So talk about those dynamics as well in terms of family and the person that's suffered the trauma or...
Well, from my for my piece of it, it's the advocacy and knowing how to advocate, knowing that you need to have authority given to you through an advance directive to be someone's advocate, or you need to fall within their hierarchy. But sometimes those are different people. Just because someone has legal hierarchy authority to make decisions for you, maybe that's not who you want. So patients need to think about, who do I really want as my advocate? Who is that right voice that I want to be, that really knows what quality of life is to me and what things I need and what things bring me comfort, and who knows when I'm off a little bit, or who knows what's normal for me and what's not. So then Laura can really talk more about how that applies to the actual treatment plan and discharge planning. But for my role in it, it's to be sure that we have the right advocate speaking to the medical team.
So if we're talking about advocates, so let's focus in on advocating. So it's a skill, right? I mean, at some point in time, it's a skill.
It is a skill. I think it's more of an empowerment. I think it's more of an empowerment of helping people understand that you have to be the voice for someone else. You have to speak up. You have to know what is off about a patient. You need to know that you have the right to ask questions and you have the right to request or refuse treatment.
So you've shared this with somebody now. Is there a way of sustaining that? Is there one thing you would advise of somebody that's now an advocate, and they've taken your message to mind?
I would really
what
say
can they
that
do to practice?
I would say that you absolutely insert yourself with your medical team, that you talk to the people, your case managers, the people on your service, that you're gleaning as much information as you can, because I think sometimes people feel paralyzed by what am I supposed to do now? It's like you're supposed to glean as much information as you can and absolutely practice asking questions and questioning things, because it should be, I don't understand what's going on, or what you guys are seeing is different from what I see at home.
And it seems like get onto the field of play, right? As well, if we're talking sports, you got it. If you like football, I don't know.
I'm with you.
I don't like it for what football does to somebody's brain, but put on the shoulder pads and get out there and
be active, be proactive. I really advocate being proactive instead of reactive. You come in reactive to a trauma, and we want you to discharge knowing how to be proactive.
So, it looks like you wanted to say something.
Yeah, oftentimes with a traumatic injury, it's your first introduction to being hospitalized, and we get to know the patient enough, and the family advocates and tells us that their behavior has been changing over time, and we may be the first people to actually diagnose dementia and set you up with resources post-discharge to follow up on dementia care with the medical team and also community services.
Interesting. Just a few last questions. I'd love to know what motivated you. You've been doing this for a long time. So what motivated you to become what you are and get involved in trauma care? And what sustains you, maybe, is the follow-on question. Those are two questions, probably.
I guess I started at a very young age. I was 13 when I was a junior volunteer at a hospital because my mother was a volunteer there. And I just fell in love with taking care of patients, talking to people. And one of the jobs we had to do back when I was very young was just keep older people entertained. And I've always had a warm place in my heart for geriatrics. And now as I age and get into the age group, I have more of a passion to speak and research dementia and delirium myself. But it's always kept me sustained just knowing that I'm helping someone else.
Keep people entertained. I mean, that's one of the words I just heard you say. That was an interesting word to hear in this context. So good stuff. I love it. And Libby, I know we've interviewed before, but maybe in the context of this, what motivated you to do what you're doing? And I know where your program started, and that's covered in your podcast. But what about you personally? What drives you?
For me personally, I had to advocate for a son needing a heart transplant and talk about needing to understand medically and being his voice, because he couldn't have a voice in that. He was too young. But knowing that I needed to understand exactly what they were going to do and how it was going to affect him, and it was choices that were going to affect the rest of his life and his quality of life. And so learning to interject and be that person that says, I'm his mom, I don't have your medical expertise, but you know what? I'm the one that wants the best for him, and I'm the one that's going to walk with him through the rest of it. So I did that at a younger age, and then advocating for my own mom through her cancer treatments and realizing, again, understanding treatment options, understanding when she said after 4 years of failed treatments when she could say enough. And then seeing patients with dementia, just realizing that day in and day out with my own work, I'm serving families all the time that say, I wish I had done this sooner and now it feels too late. Yeah. And it's such a long walk and such a long, as people call it, the long goodbye. I just realized that there's so much to learning how to empower people sooner. And I just want to be a part of that. I so desperately want people to feel like they have some say in what's going on, because I think in the health system, we all too often feel like we don't have a say. But it's about us and our lives. We, of course, have a say.
Thank you for that. And I've heard you mention that word empower a number of times. Certainly influences how you think, and what drives you to empower others and make that connection with them so they are empowered, right? You can talk about empowerment, but unless they're empowered. So thank you for the work that you're doing. Yeah, in closing, just a comment from me. I'm the podcaster and the interviewer. I shouldn't be inserting myself, but I say, very often we look at the problems in the world as existential in nature, right? And they're bigger than we are and bigger than anything we can do about it. But when you look at where the work is really done, it's generally very personal and very much in the community. So thank you for being here.
And we have a great podcast. Thank you.
Yeah, thanks.
We hope this brief but meaningful conversation offers a vital perspective on dementia care, advocacy, and the power of community. This is Dementia Air Network, where voices matter and stories connect. Until next time, stay curious, stay compassionate, and keep the conversation going.